Let me take this opportunity to thank our team for the support rendered. Well, that's my disclosure. I do not have any experience in laser angioplasty. However, I shall share with you a few of the cases that was shared with by my friends for this presentation. I shall take you through, over the next 5 to 6 minutes, I shall take you through the usefulness of laser in coronary interventions. Well, that's how the laser console would look like. It's a heavy console, almost 300 kgs. Now the neo one, it's around 225 kgs. And you could see the catheter down there. It's a user-friendly catheter. It's a monorail system, and it could easily go through a 6 French guide catheter. There are many catheter sizes: 0.9, 1.4, 1.7, 2 millimeter, and 0.9 would be the regular workhorse catheter. That's what is used in many of the centers for lacing the coronaries. Well, there are 3 unique mechanisms how a laser could work. It's photochemical, photomechanical, and photothermal. Photochemical, it means it works in mixed morphologies. It works at the molecular level by breaking the molecular bonds so that the mixed morphologies could be opened up. Then photothermal, it works on rigid materials and changes the vessel compliance. It makes the vessel compliance. It debulks the difficult lesions and make the vessel more compliant. And photomechanicals, it debulks again the mixed morphologies. It breaks down the materials due to cavitation bubble, so that ultimately what happens is when you have a difficult lesion, it debulks the vessel. It opens up the vessel so that you could push the balloons or stents easily inside the vessel. So primarily it's a jackhammering effect. As the catheter moves through that, the cavitation bubble and all the other mechanism, it opens up the vessel so that you have a path created for the balloon and the stent to move into the vessel. So that's how the laser penetrates. It almost penetrates 50 microns ahead of the tip of the catheter. It's almost the width of the human hair. Well, how is a laser going to be useful for us? It debulks the vessel, it modifies the vessel, makes the vessel supple, makes it easier for the delivery of balloons and stent inside the vessel, which makes that you could open up the balloon at lower pressure so that the distal embolization could be significantly reduced. You have a potential for a better stent apposition because the vessel has become more compliant, leading to reduction in restenosis and stent thrombus, and you also have a potential reduction in distal embolization primarily because you wouldn't have to go at very high pressures for deploying the stents, and it also allows the possibilities of using shorter stents. These are situations where laser is going to be useful in routine coronary intervention in CTOs, instant restenosis, moderately calcific stenosis, failed balloon angioplasty, and expanded stent, heavily thrombotic lesions, now still and long lesions. Well, these are a few examples. A patient who presented with effort angina post-CAB, you could see that the right coronary artery has got a difficult CTO. You could see that the guide catheter that's used, it's a Jetkins catheter, no much of backup support. The lesion was wired with a Gaia 2 wire. Despite having a poor backup support, you could see that the laser catheter moves in. That's the dot you see in the mid-right coronary artery is the laser catheter. That's a 0.9 laser catheter. It moves in without any difficulty, and once the lacing is done, you could see that there is the flow, the vessel is opened up, there's flow inside the vessel. Also, you could see that there's a small perforation in the mid-right coronary artery. So once the vessel is open, you could easily get the balloon across, stent across with the help of guide plus catheter, and then you could get a final good result. So that is one situation where a CTO wire is crossed, but then if none of the other device cross, the answer is laser. Then coming to instant restenosis, this is a patient who had a stenting to LAD as well as the circumflex artery long ago, has present with a restenosis and an acute coronary syndrome. That's the second image. You could see that the laser catheter going in, that's a 1.4 laser catheter, and then following lacing as well as angiosculpy, you could see that the vessel is fully open. Then further stent deployment is being done, and we could achieve good result. Now, this is another situation, a patient who had a left main bifurcation stenting present with restenosis, acute coronary syndrome. You could see in the OCT that it's a layered restenosis. There are areas of dark areas and bright areas. That's a layered restenosis. And following lacing and angiosculpy, you could see that the vessel has almost become normal. And finally, following stent implant, repeat stent implantation, that's the final result that you could achieve. So finally, what should be kept in mind is you have vaporization of at least some tissues over there so that distal embolization could be reduced, the vessel could be opened up. And then coming to moderately calcific stenosis, this is instant restenosis. In the frozen frame above there, you could see that inside the stented segment, there is almost 180-degree arc of calcification from 4 o'clock to 11 o'clock position. And there again, the calcification was taken care by laser. That was post-laser and post-cutting balloon. The IVS image shows that the vessel is partially cleared at least, and following stent implantation, that's the final result. And then in situations wherein you have a failed balloon angioplasty, laser is going to be useful. This particular patient had a CT of distal right coronary artery. It was failed angioplasty a couple of times. The procedure was done with an AL1 catheter wired with an Gaia wire, and in the second image you could see that the laser catheter going in and the lacing being done. So in an uncrossable lesion, you could open up the lesion with the help of lacing, and then you could go ahead with balloon dilatation, stent implantation, and that was a sort of final result that they could achieve at the end of the day. And in under-expanded stents also, laser going to be useful. Presently we heard that IVL would be helpful for us. Again, once IVL doesn't work, lacing it's an off-label indication. See that the mid-right coronary artery has got restenosis. The primary reason for restenosis was an under-expanded stent in the mid-right coronary artery, and with the help of lacing, 0.9 millimeter catheter and 1.4 catheter, it was laced, and following that you could see that the balloon could be properly expanded and the vessel was opened up. And in heavily thrombotic lesions also, it's a good catheter to use. A patient who post-bypass surgery, occluded graft, a huge graft, lot of thrombus burden, patient in hypotension, infibral myocardial infarction. In the second image, you could see that the flow is not at all good, huge amount of clots inside the vessel. Lacing was done with 0.9 as well as 1.4 catheter, and you could see that the amount of thrombus burden has been significantly reduced with the help of lacing. And finally, you could see that there is TIMI3 flow, however, the microvasculature is not really good, but then without this, probably without removing the clot, you wouldn't have achieved this particular result also. So these are situations wherein the laser could be handy in coronary intervention. I personally feel that except for the cost of the console, probably there are situations, there are definite indications for us to use laser in our routine practice. So in closing, dear friends, laser helps in easy delivery of stents and balloons inside a difficult lesion. You tend to have better apposition and expansion so that the long-term outcomes could be better, and balloon expansion also could be done at low pressure so that you tend to have reduction in distal embolization also. Thank you very much for your patience.